Good evening, and thank you for joining us. Welcome to a journal club by Physicians Association for Nutrition, Israel. We are part of an international organization of professionals like dietitians, physicians, and other health professionals, aiming to reduce diet-related diseases, improve lives, and rethink health. One of the ways we do that is by joining hands and getting updated in evidence-based knowledge on how to prevent and treat diseases by healthy lifestyle and especially healthy nutrition. This evening, we're hosting Wendy Walrabenstein from Pan, Netherlands. Wendy is a dietitian and PhD researcher, and she will present an RCT she developed and initiated with the brilliant name Plants for Joints. We will have a short Q&A session at the end of the presentation. Wendy, thank you very much for being with us.
Yeah, thank you, Ronnie, for that very nice introduction. And welcome, everyone. I'm very happy to be here. As Ronnie said, I'm a dietitian. I once upon a time, I studied economics, actually, and worked in international banking for 15 years. But it was after that that I found my passion for developing lifestyle solutions for diseases and for extending the healthy lifespan. And I will share my screen now with you. Okay, Ronnie, can you see it?
Yes, all good.
Okay, thank you. Well, as Ronnie said, I'm a PhD researcher. I'm working at the Amsterdam University Medical Center and Reade, which is a Dutch clinic for rheumatology and rehabilitation. And I'm also working at the Amsterdam University of Applied Sciences, where I'm a teacher in dietetics. And today I will share with you the Plants for Joints study. To do that, I will first elaborate a bit on arthritis, because what is arthritis? Well, arthritis is, it covers more than 150 diseases. And the three main diseases are osteoarthritis, rheumatoid arthritis, and gout. Those are the three major diseases. And at Reade, we are investigating solutions for all three of these largest diseases. But tonight, I will only discuss rheumatoid arthritis and osteoarthritis, since gout is a particular disease, and perhaps I can share the results of that study another time with you. But today we will focus on rheumatoid arthritis and osteoarthritis. So rheumatoid arthritis is a chronic autoimmune disease, and it makes our joints inflame. So the major particularity of the disease is that you have inflammation of the joints, but it also goes with fatigue, pain, stiffness, and a decreased physical function. Another particularity of rheumatoid arthritis is that people with RA, as I will call it from now, have twice the risk of cardiovascular disease when compared with the general population. And the medical treatment, let's say since 20, 30 years, we have a quite good medical treatment for rheumatoid arthritis with disease-modifying anti-rheumatic drugs. And that has made sure that in the waiting room of the rheumatologist, people aren't really invalidated anymore. So there used to be people with this grown joints, as you may recall from photographs, and because of these effective DMARDs, these disease-modifying anti-rheumatic drugs, those invalidities are way less. But it hasn't really solved the problem, because less than 20% of people with RA really have a low disease activity. So they still suffer from pain and fatigue and stiffness. And many of the people who have the medication really suffer from the side effects. So it can be treated way better than it used to be treated in earlier days, but we're far from the optimal situation. Then, and to give you an idea, in the Netherlands, for example, we have approximately 270,000 people with RA, and that is, let's say, about I think about 1.5% of the population. Osteoarthritis is a quite different disease in the sense that it is not an autoimmune disease. And often doctors call it aging, normal wear and tear. But recently, more and more, we are seeing that this disease is actually a form of inflammation as well. However, it's not, let's say, the acute inflammation that we see in RA, in rheumatoid arthritis, but it is a low-grade inflammation. And aging and wear and tear, it is indeed a disease of aging. But the funny thing is that people get it earlier and earlier. So when you look, for example, to the blue zones, you know, the 5 regions where people live easily beyond 100 years and older, and the odds of getting to 100 is 10 times higher than, for example, in the US or in the Netherlands. And in those blue zones, of course, people also have wear and tear in their joints. They also have less their joints are also weared and teared. But the funny thing is that over there, people don't suffer from the excruciating pain that they are suffering from here in the Netherlands, for example. So as you can see, also pain and stiffness and low physical function with osteoarthritis, and the prevalence is really high. 7% of the world population suffers from osteoarthritis. And in the Netherlands, for example, the prevalence is 10%. So 1 out of every 10 inhabitants here in the Netherlands suffers from osteoarthritis. And the expectations are that this prevalence will explode within the coming 10 to 20 years. And you can see this on, you can see it on this graph over here, where over here we have 2015, and in 2015 we had 1.2 million people with osteoarthritis, and you can see this very steep increase to 2.3 million people, and we have 17 million people. So it goes from 9% of the population to approximately 12% of the population in 2040. And also in osteoarthritis, we see that people have a very high incidence also of cardiovascular disease, and they have twice the risk of metabolic syndrome and obesity. And whereas for RA, we have quite good medication, for OA, for osteoarthritis, the treatment options are very limited. For OA, the only thing you have is painkilling, so analgesics, painkillers on the one hand, and on the other end of the spectrum, you have the joint replacing surgery. And in between, actually, as regard to treatment options, there's nothing. So osteoarthritis is huge, and the treatment options are limited. And the people who have osteoarthritis have a huge amount of comorbidities. And if we dig into this disease, interestingly enough, for both RA as well as OA, we see a kind of joint a commonality, actually, which is this chronic systemic low-grade inflammation. And you can see that here in the picture in the middle. And it is driven by lifestyle factors. So you see, for example, physical inactivity, obesity, dysbiosis. So this means that the microbiome is disadvantageous. You have more bad bacteria and less good bacteria in your guts. Diet, of course, also stress, disturbed sleep, and xenobiotics, that's, let's say, all the toxic substances in our environment, and of course also chronic infections, like, for example, Lyme disease. And all these environmental factors drive this systemic chronic inflammation. And the first thing you see is this metabolic syndrome. And metabolic syndrome, that's the it's a combination of risk factors that drive type 2 diabetes, cardiovascular disease, and this NAFLD, which stands for non-alcoholic fatty liver disease. And from there, we can see the development of cardiovascular disease, cancer, depression, but also immune disease. So here we have rheumatoid arthritis, neurodegenerative diseases like Alzheimer's, but also Parkinson, and then sarcopenia, osteoporosis, which is also, let's say, quite near the arthritis, and immunosenescence, which is actually the accelerated aging process, which is very much, which plays a huge role in osteoarthritis. So this is, let's say, the common ground on which both rheumatoid arthritis and osteoarthritis develops. And if we look at rheumatoid arthritis, again, as I said, we have good medication, but let's say in the 80s, we didn't have any medication for rheumatoid arthritis. And at that time, we knew that fasting was actually quite effective to treat rheumatoid arthritis. It was, let's say, a lay kind of treatment for rheumatoid arthritis. And there were some Norwegian researchers who said, well, because you can't stop eating forever, of course, if you're fasting. And they said, what could be a dietary pattern that is least inflammatory, which you could do after fasting? And they came up with a plant-based diet. And in this picture, in this graph, you can see the results of their study. They had 53 people, and they divided them in the intervention group and a control group. And they were both taken into a clinic where one group, in the control group, they received, let's say, a healthy diet. And in the intervention group, the people got a 1-week fasting protocol, after which they were put on a plant-based diet. And the dotted line is the control group, and the other line is the intervention group. And as you can see, the most important markers for rheumatoid arthritis, which are pain, morning stiffness, tender joints, swollen joints, and ESR, that is the erythrocyte sedimentation rate. It's a marker for inflammation. And you can see that all those markers went down significantly in the intervention group. And that was in 1991. It was published in The Lancet and then forgotten because the medication was so good that people thought they didn't need this anymore. That was not true, of course, because the medication is effective only for a small group of people. We also know that with rheumatoid arthritis, physical activity is very important. And actually, people who are most physically active have a 35% lower risk of developing rheumatoid arthritis when compared to the group that has the least level, the lowest level of physical activity. So physical activity is quite key in rheumatoid arthritis. Even more important is stress. And actually, these two studies made a huge impact on me because these are two studies, and one of them was a study done among 660,000 veterans, soldiers who went to Afghanistan, for example. And what they found in this group was that the people in that group who developed post-traumatic stress disorders, they had a 75 to 100% increased risk of developing some autoimmune diseases, of which also rheumatoid arthritis. So the people who had, let's say, this extreme form of rheumatoid of stress, so post-traumatic stress disorder, had twice as high a risk of developing rheumatoid arthritis. And that made a huge impact on me. And actually, that was the reason why we decided to collaborate with Leiden University, another university in the Netherlands, and there we found a great group of psychologists who helped us out with this program. If we look at osteoarthritis, on the other hand, we don't see any studies done with a plant-based diet. The only studies done with osteoarthritis are studies focused on weight loss, because most people with osteoarthritis are overweight or obese, and many researchers thought that, let's say, the mechanical load on knees and hips would be responsible for developing osteoarthritis. We don't think that that is the case, because if you look to, for example, people who have had osteoarthritis in the hands, they are also very often overweight or obese. So, and here you don't have that mechanical load, of course. So we think that the obesity link is more related to the fact that people who are overweight, and especially people who have a lot of visceral fat, so fat in the belly, they have this increased risk of this low-grade systemic inflammation, and that might be the reason that they are developing osteoarthritis. So, so the mechanical load is not explaining this osteoarthritis, but the inflammation might be an explanation for that. And if we look at studies done, this is a study done, this graph are the results of a study done by Stephen Messier, a very fine researcher in the United States, who has done great studies on diet, so weight loss diet, very low calorie diets, with or without physical activity. And here you can see that when you combine diet and exercise, that pain, WOMAC is a specific questionnaire to measure pain in people. WOMAC is very specific for osteoarthritis and is also the questionnaire we use for our study. And you can see that combining exercise and weight loss is more effective than either one of them, either diet or exercise. And then a step further, because as I said, rheumatoid arthritis and osteoarthritis are also associated with a very high risk of cardiovascular disease. And also there, we think that the linking pin is again that chronic systemic inflammation. And well, the people who join here might be familiar with the study done by Dean Ornish. Dean Ornish was the doctor who convinced Bill Clinton to go plant-based. And Dean Ornish developed this lifestyle program based on a plant-based diet, physical activity, stress management, and group support. And over here, you see the results, and you can see that it's about the diameter stenosis in the cardiovascular veins. And you can see that over here you have a narrowing of around 40%. And this lifestyle program was able to turn back the clock actually, and made sure that the narrowment of the veins went down to 37, whereas the control group who received usual care, their stenosis went up to more than 50%. And actually, this study by Dean Ornish was the inspiration for us to develop a similar program, but then for the treatment of osteoarthritis. So we developed Plans for Joints, and Plans for Joints is a lifestyle program about plant-based, whole food and healthy foods. Above all, tasty foods. And that is where Anja comes in. Anja is over here as well, our vegan chef. And she really taught the participants of our study how to cook not only healthy food, vegan food, but also delicious food. Because if it's not tasty, it's not sustainable. Plans for Joints, however, was also about sitting less, because physical activity is one thing, but the first step is to sit less. And of course, about moving more and sleeping better and relaxing more. So that was the basic, those were the basics of our program. And then we developed this RCT, this randomized controlled trial. Actually, we developed 2 of them to study the effect of this 4-month intervention, so a 4-month lifestyle program to measure disease activity in rheumatoid arthritis. And disease activity is measured with the DAS28, and DAS28 stands for the disease activity score based on 28 joints. So we measure all these joints in the hands and the knees and the shoulders to see whether it's swollen or whether it's painful. And then the second one was for the people who have osteoarthritis in combination with metabolic syndrome. So they were also overweight, had a high blood pressure, high blood cholesterol, and high blood sugar. And this is a group we call metabolic syndrome associated osteoarthritis, so MSOA. And in that group, we measured pain, function, and stiffness. And we measured that with the WOMAC questionnaire. So we had this RCT with an intervention and a control group. And of course, to make sure the control group was eager to participate, we said to them, okay, you have to join and you're randomized to the control group, but after 4 months, you'll get this program as well. And we called it a waiting list control group. So if they were in the control group, they were put on this waiting list and they were measured during those 4 months. And then afterwards, they received the program as well. And after having followed the program, all these participants are followed for another 2 years. And in the RCT, we measured everyone at baseline, halfway at 2 months, and at the end at 4 months. And then in the 2-year extension study, every 6 months. So we included people with rheumatoid arthritis, 18 years and older, with a low to moderate disease activity. So this DAS28 that I mentioned earlier, if people are below 2.6, they're in remission. So they still have rheumatoid arthritis, but you can't really see it anymore. And if they're up 5.1, then the disease is really horrible and they have to be treated directly. So above 5.1, it's not really responsible to take them into a lifestyle program. And here you have, again, these DMARDs, the disease-modifying antirheumatic drugs, and they have a bit of a delayed functioning. So if you start right now, they will work only 3 months later. So if you stop, it will also work out 2 months later, approximately. So they had to be really stable on medication. For osteoarthritis, they had to have osteoarthritis in knee and or in the hip, and they had to have metabolic syndrome, so waist circumference, fasting glucose, triglycerides, HDL, and blood pressure above or below certain levels. We also had a couple of exclusion criteria. So people who were already on a vegan diet, you cannot measure any improvement then. So they were excluded. Pregnancy, underweight, because if you are underweight and you are losing also some weight because of changing your diet, that's not really good for the study. Smoking, because that has a very high impact on arthritis. And low e-health competencies, because we had some apps they had to work with. So we excluded those people. And then the program. So as said, we started with this cooking class led by Anja. And before Corona, before COVID-19, they could follow this cooking class with their partner. And after lockdowns and stuff, we unfortunately could not invite the partners anymore, but the cooking classes were great. People were very surprised about how delicious they could make their meals. And so that was a great start. And after that, we had another 9 meetings. And in those meetings, mostly half of it was dedicated to diet, and the other half was dedicated to stress and physical activity. And we started with a full live program, and then due to COVID-19 measures, we changed into a 7 times online and 3 times live meetings. So then the results, very happy to share with you that the paper was actually published just a couple of days ago. So if you Google my name, rheumatology, plans for joints, then you'll find it. It's open access, so you can just, so if you want to read it carefully again, you can dig into it. And what we saw is that mostly women were very attracted to this study. As you can see, 95%. Rheumatoid arthritis is also more prevalent in women, so around 75% are women, but you see that relatively even more women subscribed to this trial. The age was around 55, and this group had a relatively healthy body mass index of around 26 at baseline. And over here you see seropositive, and that means this is the part of the research group. So this was around 70%, which is also the number that you see in a general rheumatoid arthritis population. These are people where you really can find rheumatoid arthritis specific antibodies in their body. So you can really see the autoimmune disease back in their blood. They have these auto antibodies. Around 30% of the RA population doesn't have any rheumatoid specific antibodies, but they have all the other symptoms of rheumatoid arthritis. And later on, you'll see why I'm explaining this quite good to you, but seropositive is something to remember. Most of them had the disease already for approximately 9 years, and the disease activity was around 3.8 on average. And as you may remember, I already told you that 2.6, below 2.6, you can really speak of remission, so no disease activity. And here you can see that these people had a moderate disease activity. So they really still had pain and swollen joints, etc. Well, what did we saw? Well, in this graph, you see that they started around this 3.7, and in the control group, they remained at that level. And in the intervention group, you saw this quite fast decrease, not below 2.6, unfortunately. They were around 2.8, but quite a steep decrease. And one of our rheumatology professors here in Amsterdam, who was quite skeptical about our study, said, well, actually, Wendy, this is what we see in medication studies. So congratulations, this is a great result. So we are very happy with this result. And Carlijn Wagenaar, my colleague, just analyzed the 1 year data, and actually they keep that lowered disease activity also after 1 year. So it's really a sustainable decrease of disease activity. And as I said, we have these two groups, seropositive, seronegative. And in the people who already have these autoantibodies in their blood, you can see that the effect is still significant, but it's lower, it's less than in the seronegative group. So for example, in the seronegative group, the seronegative group has a larger effect. And this is very interesting because the seronegative group is also really another kind of rheumatoid arthritis. And looking to these results, I actually would suggest that perhaps people with seronegative rheumatoid arthritis might start with lifestyle first instead of the medication first. Rheumatoid arthritis is known for an aggressive treatment with heavy drugs. And actually for the seronegative community, that might not be the solution. Then the metabolic syndrome associated osteoarthritis group. So the osteoarthritis group was somewhat older, so 60 plus. Some more men, but still mainly women. But also here, osteoarthritis is something that you see more often in women. A higher body mass index, 33. And you can see here the WOMAC total score. So that is the composite of pain, stiffness, and physical function was around 40. And that means that they really suffer from let's say, a moderate to intense form of osteoarthritis. And as said, this is metabolic syndrome associated. So they often also had hypertension, pre-diabetes or diabetes, and increased cholesterol levels. Oh, you can see this photograph over here because these data are not published yet. So please don't share these data yet. But here are the results of the osteoarthritis trial. And I want to underline here that this is 7% of world population, and current treatment is very limited. So if you can lower pain like this, it is really, really very interesting. So what we saw over here was that also here a steep decrease of pain already after 8 weeks. Stiffness decreased also very much. And then physical function and lower levels are, let's say, higher levels of physical function. So lower is better. So over here, you see that physical function improved also significantly in the intervention group. And this is the combination of pain, stiffness, and physical function in this WOMAC total. And WOMAC is internationally used as the primary outcome measure to measure the disease in osteoarthritis. And then, of course, weight is very important in these diseases and is also related to inflammation. And in the total group, I have pulled here everyone together. In the total group, you see a weight loss of around 5 kilograms. So that's around 10 pounds. And we see that it's the major part of that weight loss is pure fat mass. So we used the DEXA scan to measure weight loss. And we also saw a tiny decrease in muscle mass. And this is relevant because, of course, we prefer to see weight loss only in the form of fat mass loss. So I would like to improve here, but it was tiny, not that much, and relatively fat percentage went down. But we also measured fat in the liver, and we did that with half of the osteoarthritis group. And this is, you can see here an example of two patients. This is an intervention patient. She started with 31% liver fat, and after the intervention, she had 7% liver fat. And this is a control patient who went from 25% to 30% after 4 months. So this is just an example. And overall, in the 31 patients that we studied in this MRI part of the study, we saw that many of them, 60% of the total group, suffered from non-alcoholic fatty liver disease, which can be diagnosed whenever people have 5% or more fat in their livers. And over here, you can see that the median was above the 5% at baseline in the intervention group, even higher in the control group, and it increased in the control group. But in the intervention group, it went down significantly. So this was another very interesting result of our study. Then the last, I'm going to an end here. What we also saw was improvement of some metabolic markers. And this is really in line with previous studies done by Neil Bernard, Dean Ornish, and all the other people who have studied the effect of a plant-based diet. What you can see is that glucose and HbA1c, so the long-term blood sugar levels, go down significantly. LDL, the bad cholesterol, goes down significantly. Blood pressure, I think for blood pressure, you should add really let's say, an objective to lower sodium. We did not do that, but I think you could, for the people with hypertension, you could add an additional, let's say, recommendation to lower salt intake. And I think that then you could have also had a significant lower blood pressure. HDL stayed on level, which was a good level, and triglycerides went down, but it didn't went down significantly. Then what did they really eat? Well, as you can see over here, energy intake, it was a little bit underreported, but it didn't lower that much. It was not the energy intake that really caused this improvement. Protein intake could be better in the because of course, we saw a little bit of muscle loss, and I think that we could improve it with, let's say, muscle strengthening exercise and a little bit higher protein. Okay, you can see over here that they are above 0.8 at baseline, and the control group stays around the 0.8, but in the intervention group, they go down. What was major was, of course, the decrease in saturated fatty acid intake. This is a great decrease, and I think also contributed to some of the improvement. But the most important change in the diet was the increase in fiber intake. And to give you an idea, in the Netherlands, the general population consumes less than the people over here did at baseline. So this was a group already on a quite healthy diet. Well, what have we learned? Because we did this RCT, but we also did an additional questionnaire to study the process. And we organized focus groups to collect, let's say, improvement points and learning points. And what people said is they really want to take control themselves, and they want to know what they can do. And what we thought was very funny is it was the group dynamics. And one of the participants said it was almost like going to an AA meeting, which I thought was quite funny. And people were very satisfied. They gave us a 9.2 on a scale between 0 and 10 in terms of how likely would you be to recommend this program to others. And of course, this study has strengths, but it also has weaknesses. Strengths are the low dropout rate, the substantial effects, the process evaluation, and the 2-year extension study. Pro and con are the combination of multiple lifestyle factors, because on the one hand, I think that has contributed to the effect. On the one hand, we cannot pinpoint what really caused the effect, so that is tricky. We did not have an attention control. So, for example, the people in the intervention group, of course, got more attention, and the other group just got usual care. So if I would do it again, I would give them a kind of attention control, call them every now and then to give them a little bit of attention. And of course, it's quite difficult to measure really objectively the adherence outcome in diet, physical activity, and stress management. So the conclusion is this Plans for Joints program decreases disease activity in people with rheumatoid arthritis, and it decreases pain and stiffness, and it improves physical function in people with osteoarthritis, and it also improves metabolic outcomes. Sorry. The next steps are implementation. We really want to implement this program into usual care. We are still working on the extension study. We have collected poops of everyone, and they are in a freezer at -80 degrees. So we will study them as well to see in how much the fiber intake has changed really the microbiome, and whether that was responsible for part of the improvement. We are also looking at cost effectiveness, also to see whether people with RA can really decrease intake of medication, because the medicines for rheumatoid arthritis are quite costly. And we are looking for funding to make sure that we can implement it. So if you are interested or you have connections with people who can help us fund this, then please contact me. And if you want to stay tuned, you can go to this website. It's a coming soon landing page, but you can subscribe there to our email list, and we can keep you posted on the papers that we are writing and the implementation steps we are taking. I think because of time, I had a short movie, but I will just share with you the link to that little movie in which you can see 5 of our patients, and they will tell you something about how they experienced Plans for Joints. So a little bit longer, Ronnie, than
It's fine. It was fascinating. Thank you, Wendy.
So
yes, please. Thank you. So we can see everyone and listen if we have any questions. I can say that there was a small discussion about curcumin on the chat.
Yeah. So I'll first share with you a link to the video. And regarding curcumin, well, actually, curcumin has been studied in a comparative study with painkillers, and they are at least as effective as painkillers. So you have to verify whether people are not if they are not taking antihypertensives, because curcumin can also lower blood pressure. So you have to check that very well. But I would recommend at least using a lot of curry and curcumin in your food. That is always a good idea. Supplementation can be done, but I would do that under the supervision of at least a dietitian.
Great, thank you. Another question in the chat: what sort of fiber did they have?
Good question. Yeah, well, it was really a whole food plant-based diet. So they received supplementation, vitamin B12 and vitamin D. And after the 4 months, we also recommended them to take algae oils for omega-3, but that was it. And the fiber was only from their diet. So it was because we wrote a systematic review. Actually, Carlijn, my colleague, wrote that, a systematic review on the impact of diet on microbiome and inflammatory diseases. And what we saw actually was that increasing fiber through diet, so not with supplementary fibers, was more effective. So I would recommend to increase fiber by diversifying your diet and take as many plants as you can, many different sort of plants as you can eat, and increase your fiber that way.
I support that. Well, which kind of exercise did the people do?
Yeah, well, the aim was to make them adhere to the recommendations. So 30 minutes a day of low to intense activity and muscle strengthening exercises twice a week. So that was the recommendation for exercise. And we saw many people with arthritis are a little bit afraid of doing exercises. So you really need some physiotherapists or personal trainers who are really experts in osteoarthritis. Especially the group we had, of course, people who are doing a lifestyle program, they want to do something themselves. So what we noticed is that they also, in case they had really problems with their wrists, for example, that they kept on doing certain exercises which were debilitating for their wrists. So they really have to be guided, and they have to learn that sometimes they have to say no to certain exercises. If it's painful, you should not do it. So that's very important. So that I also saw another thing about many interactions with other medications for curcumin. Exactly, that's absolutely the case. Also, you really have to check that. Also, for example, with chemotherapy, it's very bad to combine curcumin with chemotherapy. So beware of that.
Okay, last couple of questions. I'm not sure I understand the question. How long do you suggest to see any impact? What do you mean by that? Whoever asked this question, I see the name Gigi. How long does it take to see impact, or for how long?
Yeah, well, actually, of course, we recommend them to do it forever. In RA, we actually saw a couple of people who were a little bit skeptical, and they tried to eat red meat, for example, or a pizza. And some of the rheumatoid arthritis patients have a setback within 24 hours. So they have swollen, painful joints within 24 hours of eating, let's say, really bad food. So a large steak or a large pizza or something. Rheumatoid arthritis can be very sensitive. Whereas, for example, osteoarthritis is a little bit more difficult. That group really has to do it for a longer time to see the impact, although in all groups we saw quite a large effect within 8 weeks. So that's quite fast. But yeah, you have to do it forever to sustain the effect, I think. Yeah.
Yeah. And to be on a healthy lifestyle.
Yeah.
Okay, let me see if I can pull out. Oh, so many more questions, but we're almost out of time. Do you want to see, Wendy, if you relate to one of the remaining questions?
Someone is asking, are there certain plant-based foods that you did not include? Not really. So we said doing this, so a whole food plant-based diet, exercise, stress management, sleep management, that's already a lot. However, some people, and that is a really a particularity in rheumatoid arthritis, we also see people who really respond to gluten. A large part doesn't respond to gluten at all, but some people with rheumatoid arthritis also exclude gluten. And they have then an additional beneficial effect. So that is the only thing we excluded sometimes. Soy, not really. Actually, most of them really react quite well on soy. So we didn't have any complaints about that. I also saw a question about fibromyalgia and arthritis psoriasis. Psoriatic arthritis, we think that that would be a great group to study next, because psoriatic arthritis is really, let's say, lifestyle related. And in our practice, we also, because we guide, of course, all kinds of people with arthritis, and actually in psoriatic arthritis, we see quite large effects. So I'm very keen on studying that. Fibromyalgia, haven't done that yet. There's a huge research gap for fibromyalgia. So I also would really love to study that. Yeah. Can you also relate these results to other chronic inflammatory diseases? Well, actually, I think that this program could work for any chronic inflammatory disease. So if you consider also that cardiovascular disease and diabetes are more and more also, let's say, categorized as inflammatory diseases, and that systemic low-grade inflammation is really recognized as a underlying factor, then I think these kinds of interventions are really a step forward for many people who suffer from these diseases.
Okay. Okay. I'm afraid we're out of time, and there are many questions left on the chat, but we're 50 minutes into this meeting, so I would like to thank everybody for participating, and Wendy for presenting this wonderful RCT program you've initiated and developed. It's amazing.
Yeah, thank you. Let me show you only the last slide.
Yeah.
I forgot about that one. Sure, because I couldn't have done this study all by myself. Are you seeing my screen now?
Yeah, not the full. Yeah, the full screen now.
Okay, because I started this with Dirk-Jan van Schaardenburg. He's over here. He's the professor of rheumatology. And all these people from Reade and from Amsterdam University Medical Center and from Leiden University have done so much for this study. And I really want to congratulate them all. Some of them are even here. So thank you.
And congratulations on the article being published.
Thank you. Thank you. Yeah.
Thank you very much, Wendy. Have a great evening, everyone.
Thank you all for joining. Bye-bye.
Thank you very much.